Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The Tachycardia algorithm simplifies initial management of tachycardia. The presence or absence of pulses is considered key to management of a patient with any tachycardia. If pulses are present, determine whether the patient is stable or unstable, and then provide treatment based on the patient's condition and rhythm. If a pulseless tachycardia is present, manage the patient according to the cardiac arrest algorithm. Implementation of this algorithm begins by verifying the presence of a pulse with the tachycardia. Most symptomatic tachyarrhythmias will present with a heart rate of 150 or more beats per minute. If a tachycardia and a pulse are present, maintain a patent airway and assist breathing as necessary. Provide oxygen if hypoxemic, and monitor cardiac rhythm, blood pressure, and oxygen saturation. Obtain IV access and a 12-lead ECG if available. The tachycardia is unstable if the patient demonstrates rate-related cardiovascular compromise with signs and symptoms such as hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, and acute heart failure. Immediate synchronized cardioversion is indicated. If time permits, establish IV access before cardioversion and administer sedation if the patient is conscious. However, don't delay cardioversion if the patient is extremely unstable. Synchronized cardioversion uses a sensor to deliver a shock synchronized with a peak of the QRS complex, the highest point of the R wave. Synchronization avoids the delivery of a shock during cardiac repolarization, a period of vulnerability in which a shock can precipitate VF. Refer to your specific device's recommended energy level to maximize first shock success. Check to make sure the synchronized marker is located on the R wave before clearing and cardioverting the patient. If cardioversion is unsuccessful, consider the following. Underlying causes, the need to increase energy level for next cardioversion, the addition of antiarrhythmic drugs, and expert consultation. On the other hand, if the patient is stable, the treatment path is determined by whether QRS is wide or narrow and whether the rhythm is regular or irregular. If a monomorphic wide complex rhythm is present and the patient is stable, expert consultation is advised because treatment has the potential for harm. The therapy for narrow QRS with regular rhythm is to attempt vagal maneuvers and, if unsuccessful, administer adenosine. Adenosine slows electrical conduction through the AV node and terminates approximately 90% of re-entry tachyarrhythmias within 2 minutes. Although it doesn't terminate atrial flutter or atrial fibrillation, it will slow AV conduction, allowing for identification of flutter or fibrillation waves, thereby allowing confirmation of the underlying tachyarrhythmia. If the rhythm converts with adenosine, it's most likely re-entry SVT. Observe for recurrence. Treat recurrence with adenosine or longer-acting AV nodal blocking agents, such as the non-dihydropyridine calcium channel blockers or beta blockers. Typically, you should obtain expert consultation if the tachycardia recurs. Adenosine should not be given for unstable or for irregular or polymorphic wide complex tachycardias because it may cause degeneration of the arrhythmia to VF.